Welcome back to the Cribsiders. This is a Medscape video recap summary of one of our recent podcast episodes. Chris, can you tell us what topic we're reviewing today?
Well, we had a recent episode where we chatted with Dr. Dale Lee from Seattle Children's about the diagnosis management of celiac disease.
What were some of your favorite pearls and takeaways from the episode?
That's a hard question because it was a packed episode. But first, we really talked about what actually is celiac disease. So just to be clear, celiac disease is an immune-mediated enteropathy to gluten, which is one of those proteins found within wheat, barley, and rye. Its symptoms are mostly due to inflammation, especially in the gut, which leads to things like malabsorption and osmotic effects that cause diarrhea and bloating.
Okay, so you mentioned some of the symptoms, but when should we really consider testing for celiac disease, and how do we test for it?
Yeah, so I think one of the big takeaways I had when we first started talking to Dr. Lee was he really wanted us to know that we should be having a really low threshold to test. He actually equated to celiac disease similar to lupus in the room world as celiac disease is to his GI world, because it's one of those great mimickers. You can see all sorts of symptoms. When you're looking at GI symptoms, we talked about abdominal pain, distension, constipation, although he was clear to say that there's no hematochezia in celiac disease. However, there are a bunch of non-GI symptoms, including difficulty focusing, migraines, rashes, joint pain, and faltering growth. So, if you suspect someone has celiac disease, then he recommended the gold standard testing really should be a TTG IgA as well as a total IgA. In terms of other testing, there are lots of other scenarios such as seronegative cases or patients with low IgA levels, but that's a little outside the realm of this talk right now. But I definitely recommend our listeners and our viewers to check out the full episode for some of those specifics.
Okay, so you mentioned labs, but what about endoscopy? Is there a role for that in diagnosis?
Yes. So endoscopy can be very useful in the diagnosis by biopsy. I think one of the other takeaways I got from this discussion was that you have to remember that a patient really needs to be consuming gluten for the biopsies to be accurate. Therefore, if you're doing your testing, you're doing your screening, and you get a positive serologic screen, don't tell the patients to abstain from gluten quite yet. All right? Tell them to wait for their GI appointment. And, we understand that sometimes it can take a while to get into these GI appointments, and if the child's having lots of issues, Dr. Lee recommended reach out to that GI doctor. They will probably be able to get you an earlier appointment.
Okay, so keep eating gluten until you follow up with gastroenterology. Got it.
That's right.
What are some other tests that we should screen for after diagnosing celiac disease?
So there are a couple different tests that he says that he uses to screen and also for follow-up, but he recommends at least starting with one like a CBC, because he likes to look for nutritional deficiencies such as iron deficiency anemia. He also checks vitamin D levels. He gets a liver function panel. If he finds that his celiac is pretty poorly controlled, he'll do a DEXA, and then he'll do some other screening too, like looking for other autoimmune diseases, like for diabetes, thyroid diseases, and autoimmune hepatitis.
Okay. Let's talk a little bit about treatment. I assume that avoiding gluten is the mainstay treatment. Is there anything else we should consider?
Yeah, so that really is it. Complete removal of gluten is the goal. And, the patients, and when you talk to patients, you really have to be conscious about talking about what is cross-contact, or sometimes called cross-contamination of foods, because for some patients, that even small amounts can cause significant issues for patients and prevent them from having progression or resolution of their symptoms. So talking to them, especially for school-age children as they're going to school, talking to the cafeterias on how they can make sure there's no cross-contamination, or if you go out to eat, talking to the restaurants on how they handle their foods before they get foods that are gluten-free. These are difficulties that patients will experience when they eat.
Yeah, I can imagine it's a challenge, especially for young kids to get used to such a different diet. Well, awesome. Anything else that we learned on this episode that you want to share?
Yeah, so Dr. Lee really talked about what we call he calls the 4 pillars of celiac management and monitoring, just to see if a patient's really responding to a gluten-free diet. So number 1 is symptom improvement. So some patients get immediately better, but other times it takes weeks to months to see any changes, especially when one of those changes might be that you're looking at is their growth. Number two is labs. So one of the main labs that are followed is that TTG IgA, and they often will see these titers improve over time. They will also continue to do the screenings like we talked about before in terms of CBC and diabetes and things like that if they need to. Number three is working with a dietitian. So this is one of the important third pillars that he really wanted to strike home to talk to us about, was really these patients have to have a close follow-up with their dietitian, have regular appointments to check whether they are on a gluten-free diet, answer any questions, and help discuss barriers, because really there are a lot of barriers to having a gluten-free diet. Now, the fourth pillar is actually sort of the optional pillar. That's repeat endoscopy. So it can be helpful if patients continue to have symptoms or have labs that remain abnormal or don't improve. But for a lot of kids, they may not need to be required to have a repeat endoscopy if pillars 1, 2, 3 are going really well. Now, just to be clear, in comparison, for a lot of adults, the mainstay of therapy for adults is to get repeat EGD 12 to 18 months after diagnosis. So just for comparison, just understand that that's there. But hopefully for most children, if pillars 1 through 3 are good, you don't have to do endoscopy.
Perfect. Well, thank you all for joining us for another Medscape video recap of the Cribsiders Pediatric Podcast. To listen to a full episode, you can download the episode and others on our podcast, or check out our website at www.thecribsiders.com. Thanks for listening.
Bye.